Hi, this is Dr. Lori Gardner from Nicholls State University. Today's lecture is Psychiatric Evaluation, Diagnostic Tests, and Differential Diagnoses. We will go over the psychiatric evaluation in detail. We will even include the medical evaluation. We'll talk about different diagnostic tests that are used and how do you come about getting your differential diagnoses and your diagnoses. The objectives, you'll demonstrate competency of the psychiatric assessment, interpret laboratory data used in psychiatry, show competency in analyzing assessment and diagnostic findings in determining actual and potential diagnosis for clients with common psychiatric disorders. So we'll start off with the diagnostic interview. And the first thing you're going to do is build a therapeutic alliance with your patient. That is the groundwork for any psychiatric treatment, building a sense of rapport and trust. Because if the patient does not trust you, they will not be back. If they don't form a therapeutic alliance with you, they're going somewhere else. You're not going to form that with everybody. You may not be everybody's cup of tea, but you want to work to form that therapeutic alliance with all the patients come through the door. You're going to obtain a psychiatric history because without it, you can't diagnose or treat the patient. You need to get a very thorough psychiatric history, and I'll help you to understand how to go about doing that. You're going to interview the patient because you need that information to form a diagnosis, correct? So while you're obtaining the history and interviewing the patient, you are evidence gathering. That is very essential to form your diagnoses. And you're going to negotiate a treatment plan. Yes, you're going to negotiate that treatment plan. You are the subject matter expert. How you present the treatment plan to the patient is very important. Work with your patient. They're not going to know what you know. But if you present it to them in a way that brings them in to help with the treatment plan, you're going to get a better overall response from the patient. So the history in the psychiatric review of systems, and I have this in several different places, so you're gonna see it more than once because it's important. You want to know any history of any significant medical issues or hospitalizations, comorbidities. That's important, right? For different medications that you're going to prescribe. So you need to know what their medical history is. Do they have any history of past psychiatric hospitalizations or any treatment by a mental health provider? Have they had any changes in their weight, their eating, their sleeping, or their sex drive? And there any history of any kind of physical, emotional, or sexual trauma? You're going to want to know if they have any legal involvement. Have they ever been arrested? Do they have any restraining orders against them? Have they placed any restraining orders against someone else? Are there any pending legal issues? So you always want to find out past and current. What does their social network look like? What kind of social supports do they have? And we'll go over that in a little bit more detail about the social network. Any history or current substance use or abuse? Have they had any treatment? You may have to spell this out for the patient. You may have to list all the different substances that they could have possibly used. Have they been taking anything that was not prescribed for them? Are they coming in to you for an ADHD assessment and they say, oh, well, wait, I've been taking my friend's Adderall. Is that something that they're supposed to be doing? Are they supposed to be using their friend's Adderall? So you want to know. The best way to get information from your patient, I find, is to let them know that this is a judgment-free zone and you need all the information to be able to treat them effectively. They're usually pretty good about giving up information once they know you're not going to be biased against them because of what's in their past. So the interview, you're going to do a psychiatric review of systems, and everything that you're gathering, you're going to use the DSM-5 TR for formulating your diagnosis. So the interview is important in forming a diagnosis. Without it, you can't form one, right? Evidence gathering and assessment are essential to formulate the diagnosis and the treatment plan. And of course, we use the DSM-5 TR for all of our diagnostic criteria. So you want to have that handy. I have a DSM-5 TR everywhere. I think I own about 3 or 4. There's a pocket guide that you can use if you're working in the hospital. If you're in a clinic, you want to use that. Don't ever feel like you know too much to pull out that DSM-5 TR. You're going to use it a lot in this program, and you will continue to use it a lot when you graduate. Keep it handy because our criteria comes from the DSM-5 TR. So the steps in diagnostic reasoning. First, you have to organize the information that you get. So you collect everything. It has to be organized. You're going to synthesize it, and then you prioritize. What do you need to do first? So if you have all of this information you've gotten from a patient comes in, they're depressed, they're anxious, they want to be tested for ADHD. They've never had a history of ADHD, but that's on their list. They're PHQ-9, they have a moderate to severe depression. Their anxiety is through the roof. Prioritize the information that you received so you understand what are you going to treat first. And then you're going to develop a clinical opinion and formulate your diagnosis. Remember, organize, synthesize, prioritize, and then develop your plan. So, what are some of the components of the psychiatric eval? Well, it starts off with the chief complaint and use the patient's own words. What are they here for? Some chief complaints are rather colorful, and I usually put those in quotations. Sometimes they're maybe very simple, or their chief complaint may be very lengthy. But the chief complaint is what brought them in to see you today. The HPI, their past psychiatric history, any substance use or abuse, their past medical history, their family history. And I usually like to do 3 generations of family members. So I'll ask about their parents, their siblings, their grandparents, both sides. You want to know if it's maternal grandmother, paternal grandfather. Make sure you get that distinction and keep a track of who has what. Also, their developmental and social history. Did they walk on time, talk on time, potty train easily? Did they have a 504 or 501 plan, 504 plan in school? What type of issues may they have had when they were developing, and also social history. Where do they live? Who do they live with? What type of relationships? We'll go through that a little bit more later in this lecture. And of course, the review of systems, the mental status exam, and your diagnoses. These are your parts and your treatment plan. These are all the components of a psychiatric evaluation. So let's talk about the history of present illness when they're coming in. So, are they having any hallucinations? I always ask, are you seeing any visions that other people can't see? Or do you hear voices that other people can't hear? You may get some colorful explanations. Are they having any delusional thinking? Any paranoia? Is everyone out to get them? Maybe someone is stalking them that's not truly stalking them. Maybe everybody at work is against them. Have they been having any mood changes, any mood swings, any anxiety? Have they been having any homicidal or suicidal thoughts or ideations? Are they having any crying spells? And if they're having any crying spells, how often are they having crying spells? Any sleep disturbance? Are they having trouble falling asleep, staying asleep? Are they sleeping too much? What time do they go to bed? What time do they wake up? How many times are they waking up throughout the night? Can they easily fall back to sleep? Are they having any appetite disturbance where either, and I usually relate that to their mood. So I'll ask, are you having any problems with your appetite related to your mood? Some people get upset. They're so upset they can't eat. Some people get really upset and they eat their feelings. What about their energy level? Are they having extreme fatigue? They just can't get up, they can't get going. Or is their energy level very good, actually through the roof, where they're having periods of increased energy? Are they having any anger, irritability? Does the least little thing set them off? Do they have pressured speech? Now, they may not understand what pressured speech is, but you'll understand when they're having pressured speech when you're doing your assessment. Some questions you may want to ask them about their history of present illness would be, what's been happening over the past week or two that brought you into the clinic? So they can tell you in their own words. Do you think any particular events have caused this problem or made it worse? And have you had treatment for this before or is this new? So a lot of our patients are chronic. You'll see them often, but you will get those new patients in and you need to ask them, is this something that you've been treated for before? How were you treated and was that treatment effective? So let's think back to advanced assessment. What are the components of the HPI? Onset, duration, any changes over time, anything make it worse, anything make it better. So when did this happen? How long has this been happening? Have you noticed any changes? Um, is there anything that triggers it or makes it worse? Have you done anything to make this better? I mean, is it being with friends, any medications, any meditation, journaling? You want to know all of those components in your HPI. And believe me, insurances want to know if you're assessing for a full HPI. Did anything bring this about? Like maybe an argument with a spouse, maybe a death of a family member, maybe they were fired from a job. And have they attempted any solutions for it? And what kind of current stressors do they have at the moment? So, with the past psychiatric history, you also want to get a date of any treatments, any hospitalizations, where were they treated, who was the provider that treated them if they can remember, what medications did they take, and were those medications effective? Did they have any side effects? Are they currently in counseling? Have they ever had counseling before? Response to treatment, hospitalizations we talked about, and of course their social and occupational functioning. So where do they live? Who do they live with? Do they have a secure home? Are they safe? Are they working? Are they in school? How long have they been working? So you want to get a really good history to know your patient. Um, how old were you when you first had these symptoms if you have an adult that came in? So I'll have some students that come in and they have anxiety, and I always want to know, were you ever treated for this, and about what age were you when you were first treated? How many episodes have you had? So have they had a remission before? Is this something that's recurrent? And when was the last episode before this one? So is this the first time? Is it a single episode? Is this something that's recurrent? So they've had this before, they have it again. Is it continuous? Is it intermittent? So is this something that they experience randomly? Or is this a chronic problem? And is it getting worse? Is that what brought them in to see you? Is this getting worse? When you're talking to them about substance use, you want to know the type of drug and their drug of choice. How do they use it? Everybody doesn't use it the same. Do they snort it? Do they inject it? At what age did they first start using any substances? And about how much can they quantify about how much they're using? So that may be history. Are they still using it currently? And if so, how often are they using it? When was the last use? Can they explain a pattern of use? So is this something social? Is this on weekends? Is it when they're stressed? Have they developed a tolerance or withdrawal? If they've tried to stop using it? And are there any consequences? Like, have they ever been arrested? Have they ever been fired? Have they had falling out with family members over their substance use? And is it associated with this current problem? You want to ask about, of course, their past medical history. So you want any current and past illnesses, any hospitalizations on the medical side. Have they had any surgeries or procedures, any kind of injuries, treatments? What medications are they taking in general? Not just psych meds, but also their medical meds. And do they have any allergies? What are they allergic to? What was the reaction? Was it mild, moderate? Was it severe? Did they reach their developmental milestones on time? For females, you want to get a good female history. How old were they when they had their first period, when they had their first, when menarche? What was the first date of their last period? You definitely want to know this in childbearing women, women of childbearing age. You want to get that last menstrual period. You want to know if they've ever been pregnant. How many pregnancies have they had? Have they had any abortions? Any spontaneous abortions? Get a good detailed history. If it's older females, have they reached menopause? When did they reach menopause? And have they had any vaginal bleeding since menopause? So a little mnemonic for screening questions that you can use MePause. Do you take any medications now? Do you have any medical illnesses? Do you have a primary care provider? You want to know. I always get the primary care provider's name and phone number if they can give it to me, or at least a location where I can look them up. Have you had any allergies, reactions, or side effects to any medications? And have you had any surgery? So those are just, it's a quick mnemonic to remember some of the screening questions that you have to ask. Family history, again, the genogram, I use 3 generations. Is there any medical illness, any cancer, hypertension, heart disease, thyroid problems? I go down a whole list to get the medical illness. Any personality issues in the family or any psychiatric history. So when you ask about psychiatric, any mood disorders, anybody with psychosis, has anybody attempted or completed suicide? Anybody with any substance use? When I'm asking about the family history, I'll ask the patient, does anybody have or is thought to have any of the problems? Because everybody doesn't get treated. So sometimes, Aunt Bertha may have what they think is bipolar disorder, but she's never been treated. Has any blood relative ever had any depression, anxiety, any mania, or any schizophrenia? Have they had any psychiatric hospitalizations? With your younger population, you'll find they really don't know, or if they're adopted, they can't give it to you. Sometimes they just don't know because families don't talk about it. You want to get a good social history. So, what is their current living situation? Are they employed? What is their highest level of education? Any current relationships? Some good questions to ask if you want to know about their social history is, tell me a bit about your background. Tell me about your current living environment. Who lives in the home with you? Tell me about your school or work experiences. And then tell me about your current social support network. So I have a lot of patients that are in Seattle, and their family is not necessarily their blood family. Family is who they make it. So I like to know about who is that social network? Who do they turn to for support? Do they have anybody that they can turn to for support? Then we'll do the medical review system. So you're like, why do I need to know about the medical? We're in psych. But everything is not just going to be psychiatric. So you need to be able to ask. Now, most of your patients coming in, especially the younger ones, won't have any issues. It's going to be really easy. Those older patients, if you're seeing older patients, like I've got some that are 80s, I have to go through these medical review systems. Sometimes I have to go through this just to get the medicines that they're on because they don't remember until I ask them about their review systems. So, a survey of the medical health may raise suspicion to warrant more specific inquiry. Questions and answers can be common to more than one area of consideration, and redundancy can help the patient recall important facts. Like I said, once I ask some of these questions, then they remember medications that they're taking. Depending on the answers, further elaboration may be necessary. So, first, you want to explain to them why you're asking these questions about their medical health. Of course, some mental health patients think, why do you want to know this? So, you want to explain to the patient that it's to help you understand their situation better. So, you're going to ask them several questions. And some questions may seem unrelated, but they are important to help you understand their health. So, when I get a new patient in, and I've got to do the whole psych eval, I usually tell them on the first visit, I am going to be asking you a lot of questions, gathering a lot of information on this visit. And that way I can see how I can best help you. But I need to know all of this information. And they're usually very good with me asking all the questions that I have to ask. So, general. Have they had any problems with their weight? Have they lost weight that they weren't trying to lose? Have they recently gained a lot of weight and they don't know why, or is their weight stable? What about their level of energy? Is it about the same? Do they have more or less? The sleep quality, same questions we ask. Any trouble sleeping, falling asleep, staying asleep, maintaining your sleep, or sleeping too much? Have they had any recent medical treatment, tests, or emergency room visits? Any fever, chill, sweating, temperature intolerance, or pain? We'll ask them a little bit about their head, ears, eyes, nose, and throat. And again, with some patients, you won't have to go through all this because they're generally healthy. But have you had any changes in your vision? I'll document if they're wearing glasses, any mouth sores, dental issues, Any nasal problems, discharge, voice changes. Some of this will be important that we're going to go over when you're prescribing medications because your patient may be having some side effects. Is there any history of pain with breathing? Do they have some kind of cough they can't get rid of? Any shortness of breath? Any snoring? Snoring is important. Do they have any sleep apnea? Any kind of exposure to toxins? Are they wheezing? Do they have a diagnosis of COPD? You want to know their respiratory status. It's important. If you ask two things, you want to get respiratory and cardiovascular. If you don't remember to ask any other symptoms, cover those two. So, have they had a heart attack? Are they having any chest pain or pressure? Are they having any swelling? Do they have a history of syncope or palpitations? Are they having any limb pain? Do they have trouble where they have to sit up to sleep? Do they get short of breath with exertion? Do they have any nausea, vomiting, constipation, diarrhea, loose stools? All of that is important when you're prescribing medications because you're assessing for not only any kind of medical issue, but are they having any side effects? So I'll let you read the genitourinary. Um, are they having any nocturia? Because guess what? That's going to keep them up at night, right? Any incontinence? Any frequency or urgency? Are they having any anemias? Any thrombocytopenia? Any agranulocytosis? Now, you're not going to ask them, do you have agranulocytosis? Because they're probably not going to know. So you're going to be assessing their labs. But you can ask them if they're having any abnormal bruising, any clotting, or if they're using any kind of blood thinners or aspirin. For females, last menstrual period. If they're of childbearing age, definitely you need to know this. Any sexual activity, any changes in mood associated with menstruation, any past or current pregnancies, neurological. Have they had any deficits, current or past, in their sensation? You want to monitor, observe their gait. You can observe their gait whether you're doing in person or telehealth because you can get them to get up and move. Just because you're doing telehealth doesn't mean they just have to sit in front of the computer. You want to assess for their coordination, ask if they're having any numbness, ask if they're having any headaches. Any weight changes, dry skin, any hair loss. If they're having any hair loss, is this something that they're causing? So do they have like maybe trichotillomania and they're pulling their hair? Do they have any menstrual irregularities? Musculoskeletal, do they have any prosthetics? Have they had any joint replacements or surgery or any known disorders? And then you want to check to see if they have any rashes. Rashes are um, especially if they're associated with a drug. So if you've prescribed something like lamotrigine, then of course when they come back, you need to be asking them if they're having rashes, right? Because and you specifically want to ask them if they've ever had Stevens-Johnson syndrome. Any changes in their hair, skin, or nails, any psoriasis, any acne, because acne may affect their self-image, right? Um, and then ask if they've had any skin biopsies done. So the psychiatric review of systems, and we're going to go over each of these individually, consists of mood, psychosis, anxiety, obsessions and compulsions, any trauma, any disassociation, any somatic concerns, any eating and feeding issues, sleeping, or substances and other addictions. Um, Recently, I have either she's 14 or 15-year-old, And she realized the somatic issues that she was having. She had pneumonia for a while, and then after the pneumonia, she still had these lingering symptoms. And then she realized that she had really gotten better, but in her mind, she was still sick. So she was having some somatic symptoms. General appearance, emotions, thoughts, cognition, judgment, and insight. So you want to know about what are they dressed appropriately for the season? How are they dressed? I usually make a note of what they have on, their hair color, if it's a patient who changes their hair color often, if they have tattoos, if they have multiple piercings. And sometimes these changes are associated with mood. So for appearance, what are they wearing? Are they dressed appropriately for the season? Appearance also includes their gender, their ethnicity, their cultural background, their actual age, and their apparent age. So do they look their stated age? Do they look older than their stated age? Um, their style of dress. Is it casual, formal? Are they in a hospital gown? Do they have a lot of jewelry? Are they naked? Some of you may work in the hospital, so your patient may not be dressed when you go in. For hygiene and grooming, are they unkempt? Are they disheveled? Are they clean? How is their hair styled? What about makeup? So, are they malodorous? I have a 16-year-old patient that I have been seeing probably for about 2 years now. And initially, she was very depressed. She had a lot of trouble in school, issues using some substances. She's a whole lot better now. And now she's starting to wear makeup. So for the longest, she never really did her hair. She never really wore makeup. The last couple of visits, she is like fully made up. So I do document that because now I'm also making sure she's not having any kind of manic episodes, that her makeup at the last visit was a lot more prominent than the visit before. So you always want to make notes and keep track of those things, because I may see this girl again and maybe she's not wearing makeup. Maybe her mood is deteriorating, or maybe she's got on way excessive makeup and I need to monitor to see if she's having any mania. What about their body? Are they skinny, slender, maybe average or stocky? Are they overweight or obese? Are they cachectic? Are the posture, is it rigid? Are they sitting upright? Are they stooped? Are they lying down? And is their gait normal? Is it staggered? Are they shuffling? Do they have a shuffling gait? Are they waddling? And any physical abnormalities, any kind of deformities that you may notice, their hair pattern, tattoos and piercings, like I mentioned before. I do have a young teenager who has trichotillomania, and so right down her part is very pronounced because she pulls her hair there. So that's something you want to make note of. And then their behavior, like their movements. Do they have any psychomotor agitation? Any psychomotor retardation? Are they fidgety? Frequent positioning? Do they shift a lot? What about any foot tapping or knee bouncing? And you'll understand why all of these movements are important as we progress through the program. But you want to make a note of their movements. Are they tapping their feet constantly? Are they pacing? Are they hyperactive? Are they having any compulsions? Any repetitive movements? So sometimes when I'm assessing for ADHD, especially in children, the little ones, I can be talking to the mother and the child is bouncing off the walls, all over the place, can't keep still. So I make a note of that so you can assess for progress as you go. Some patients don't realize that they're constantly tapping their feet on exam, but you're paying attention to what that patient is doing. You want to definitely monitor for extrapyramidal symptoms. So that's the importance of their movement. Are they cooperative? Are they appropriate? Are they dramatic? Sometimes you may have a patient that's dramatic. Are they childlike? Entitled? Are they defiant? Are they hostile? Maybe evasive? Are they guarded? Are they judgmental or critical? Are you trying to do an assessment and they're so distracted that you have to keep honing them back in? Are they really sullen or somber? Are they subdued or withdrawn? Eye contact. Are they making eye contact with you? Is it intense? Is it piercing? Is it periodic? Or is their eye contact appropriate? Are they avoidant, or they're not really looking at you, kind of keeping their eyes down, or maybe even keeping their eyes closed? These are things you want to document. Their speech. For quantity, is it verbose? Like using or expressed in more words than are needed? Are they very talkative? Is there like a reduction in their speech due to their mental dysfunction? Are they mute? When you assess volume, are they yelling? Is it appropriate? Or is it loud? Or is it so soft and mumbling that you really have to dig to find out what they're saying? Are they monotone? Maybe whispering or screaming if it's a child? I had a older adult, she may have been 69, and she was very, very childlike, spoke very, very soft. I could barely hear her. So these are all things that you have to document so you remember. And then also, say you're seeing a patient today, and then I have to see them tomorrow. Your assessment, I'm going to review your assessment before I even see the patient to kind of get an idea of what I'm walking into. So if you haven't documented well, and I'm documenting all of this, and it's only been 2 days, I'm like, well, what happened to this patient in these 2 days? If was there a drastic change in these 2 days? Or maybe something wasn't documented. What about their rate of speech? Is it flat? Is it pressured? Is it normal? When we talk about fluency and rhythm, is it fluent? Is it clean or staggered? Do they have a staccato where there's pauses in between the words? Do they stutter? Are they stuttering? Are there any latencies, or is it accented? Are they having difficulty speaking because they're really weak and the muscles that are used to speak are impaired? So when we talk about mood, use quotes when reporting their mood. So that's a subjective response to a question about how the patient is feeling. I always ask them, how you doing? I'm good. It's been a bad week. I'm not doing good. I'm sad, or I'm okay, or I'm so-so. So it's what they tell me. And then, is it congruent? So are what they saying congruent with how they're acting? So use quotes when reporting. Attempt to clarify that it is a feeling rather than a thought. Their affect. So we talk about their affect, the quality. Are they sad, suspicious? Are they anxious? Are they panicked? Are they ashamed or irritable? Are they angry? Maybe frustrated because they don't want to be here. You may get somebody who's forced to come to see you, or they're in the hospital and they don't want to be here, so they're so frustrated. Is it euphoric? Are they giddy or happy? Do they have a euthmic state where it's just like an emotional balance and tranquility? So there's like, what about the range? Is it restricted, constricted? Is it broad or is it narrow? Is their degree flat? Is it blunted? And you'll see blunted a lot with schizophrenic patients who are medicated. Is it indifferent? Is it appropriate? Is it exaggerated or dramatic? When we talk about stability, is it fixed? Are they labile where they're having frequent mood changes and intense emotions that are disproportionate to the situation? When we talk about congruency, again, is it congruent with their mood? Is their affect congruent with their mood? Or is it incongruent with, if it's incongruent with which aspects? We talk about the appropriateness related to the situation, like are they crying, which they're sad and they're crying? Are they so sad something really traumatic just happened, but they cannot stop laughing? Or are they stoic? And so reactivity, and that's the degree to which the effect is influenced by external factors. We talk about thought process or their thinking, which thought process is organization, relevance, and flow. Is their thought process linear, goal directed? Is it circumstantial? Is it tangential, where that's a pattern of thinking, where someone frequently drifts away from the main topic of discussion, jumping to unrelated ideas, and they never fully return to the original point? That's tangential. Do they have a flight of ideas? Are they rambling? Do they have loose associations where they're loosely connected or unrelated? Example of loose associations. I ate a sandwich and that dog is big. What's the association there? Is there any derailment? Are they speaking in a disorganized way? Do they have a lack of connection between their ideas? Are they having word salad? Do you guys know what word salad is? Word salad is incoherent processes where it's difficult to create consistent speech. The words are random and unrelated. Once you hear it, you will know exactly what word salad is. It's really difficult to understand what they're saying. So, like an example of word salad would be the blue sky is eating a purple cat while the clock dances on the moon and the trees sing in the rain of yesterday's dinner. Did any of that go together? Did y'all get that? Okay. And so, or thought blocking, where it's a sudden and involuntary interpretation in the person's train of thought, and it causes them to abruptly stop speaking or thinking mid-sentence. I have a young 15-year-old who has thought blocking. We could be doing a very good assessment, and she's talking, and then all of a sudden, nothing. And she cannot think about what she was talking about. Like it will not come back to her. Her parents call that her freeze. This is commonly seen in conditions like schizophrenia, where the thought process seemingly blocks without explanation. So, or are they incoherent? When we talk about thought content, overvalued ideas, paranoia, are they irrational or psychotic thoughts? They may have bizarre or non-bizarre delusions or fears or phobias, thoughts of self-harm or harm to others. So we talk about their perceptions where it's hallucinations or illusions. They may have like a depersonalization. They may have micropsia, which is little people, or macropsia, where it's giants. So they have this perception in their mind. And their distress level. Do they have these ego dystonic thoughts that are inconsistent with a person's values, self-concept, or beliefs? Okay, so we talk about cognition. What is cognition? When we're assessing cognition, we're going to assess their level of consciousness. So describe what the patient responds to. Loud noise, tactile, calling their name. Are they responsive? When we talk about orientation and attention, are they oriented to place, time, situation? Are they attentive and attentive? If they're not oriented to person, this supports a psychiatric diagnosis rather than a neurological one. So we can do the serial sevens, have them count down to from 100 by 7, or spelling world or table backwards. Memory, both immediate and delayed. After 5 minutes, we can do like a recall of 3 unrelated words. Blue ball, C, and then 5 minutes later, ask them to repeat those words. You can also do similarities and you can do proverbs. You can see, is their memory loose? Is it impaired? So you want to document all of these things. Their insight. So is it full, is it partial, or is it impaired? And I always tell students, if it is impaired, you need to say why it's impaired. Just putting impaired does not help you to remember what happened. It won't help the next provider that's reading. So full judgment, then they recognize that their symptoms are part of an illness and aware of the outcomes given the treatment versus no treatment. If it's partial, then they recognize symptoms are part of the disorder. They can understand why others may be concerned, but they don't believe, that there's evidence of it. And impaired, I would say they deny having any problems. They can't understand the risks or benefits. They don't even know why they're there. They don't know why you're seeing them because they're fine. They can't understand any concerns of others as it relates to their illness. So you always want to document for sure how their insight is, and if it's impaired as evidenced by what? Their judgment. So it describes how the patient acts about the situation. So, you can also check their capacity to make good decisions and act on them. You can use hypothetical examples to test their judgment. Like, what would you do if you found a stamped envelope on the sidewalk? It's better to use a real situation from the patient's own experience to test their judgment. It's also best to describe examples from life to quantify poor, fair, and good characterizations. For example, do they come to the emergency room for help when their symptoms flare? Or did they ignore the symptoms and they were brought in by the police due to some kind of public endangerment? Motor, their muscle strength, their coordination, any extrapyramidal function, these are very important. And why is it important? Because you need to know, can they walk normally on their heels and toes, rise from a chair without using the arms? Are there any signs of muscle wasting? Are they having any fine finger movements like tapping their thumb and index finger rapidly? Is there any pronator drift? You probably won't see that in the clinic, possibly in the hospital. I doubt it. That's usually a neurological sign that indicates there's weakness in those upper extremities. Reflexes, you can check their biceps, triceps, knees, ankles. And then coordination. Can they put their finger to their nose? And slide the heels from the knee down the shin. If they can't do this, usually you might want to refer them to a neurologist, because if they can't do the knee down the shin smoothly, then they have some kind of neurological problem going on. Their station and their gait, again, upright posture, normal heel strike, normal arm swing, or are they shuffling? Any abnormality or dysfunction in their gait, you should refer them for further evaluation. And some of the red flags that you might need to look for would be abnormal muscle motor tone. Why are they not coming up? Let's see. Oh, there we go. Abnormal motor tone, where there's common findings in patients taking antipsychotic medications. They may have the EPS symptoms, they may have dystonia, akathisia, Parkinsonism. If these findings are noted without a known precipitant, then they should be referred out to neurology for a further workup. If they have abnormal blinking or lack thereof, any impaired fine motor skills, any facial grimacing or tics, these are red flags, any agrapathesia, any chevron movements, any coriform movements, dysdakinesia. So what are the coriform movements? Those are repetitive and rapid jerking. They're involuntary, but they're well coordinated movements. And those are usually associated with Huntington's disease. Astrognosis, that's an inability to discriminate between objects based on touch alone. And that could be associated with a brain lesion. Dysdiakinesia, that's the inability to perform rapidly alternating hand movements, and that can be associated also with posterior cerebellum lesions. So we're going to kind of go over the physical exam really quickly because you guys won't do a lot or full physical exams, but you need to be aware of what you're expected to do in certain situations. If there is a problem with their medical review systems, you definitely want to do a full physical exam. You guys learn this in advanced assessment, so it's not foreign to you. Always document your vital signs, your temperature, your pulse, your respirations, and your blood pressure. These are particularly important, especially for certain medications that you're going to prescribe. You can calculate the BMI, but most EHR programs are going to do that for you. And normal BMI is 20 to 25. Overweight's 26 to 29, and obese is anything greater than 30. So you need to track weight and BMI because a lot of medications that we prescribe can cause weight gain in patients. Some can cause anorexia in patients. So tracking their weight and BMI is essential, especially when they're on antipsychotic medications, because they're known to increase their weight and the risk of obesity, diabetes, and hypertension, hyperlipidemia, and some secondary cardiovascular and cerebrovascular disease. Antipsychotic medications can cause orthostatic hypotension and tachycardia. So educating patients about proper hydration and slow titration of medication helps to reduce these risks. Eyes, ears, nose, and neck. You're really going to say, do they have full range of motion? Again, if this is a young, healthy patient, then this is going to be a normal exam for them. Skin, you want to assess for any unusual moles, any color variation, if it's elevated, any border irregularities. You're not going to treat this, you're going to refer them. So you can pretty much ask them if if they have any moles, they can show it to you. But you're not going to disrobe them to assess for moles. The chest, you want to note that they have unlabored respiratory effort without use of any accessory muscles. There's no tracheal deviation. There's no pulse deficits. Their lung expansions should be symmetrical and they shouldn't have any adventitious sounds. Their belly should be contour but symmetrical without scars. If you're going to auscultate, you need to do that before you palpate to avoid any stimulation of the bowel sounds. Percussion should be done to note any areas of dullness or tympany. You're probably not going to do this in clinic. You may do it in the hospital. Musculoskeletal, again, general posture, strength, symmetry of their upper and lower extremities. Okay, all right. So note any areas of swelling, guarding, or deformity. Note any symmetrical full range of motion of major joints. Adolescents should be screened for scoliosis. This is usually done in the school by the school nurse, so you won't do this. Pay special attention for signs of neglect and abuse or history of unusual injuries. You will do that. Frequent injuries, burns, bite marks, various stages of healing. You will be on the lookout for that. Bruises on padded body parts such as the trunk, buttocks, back of thighs, and chest. These are things you are going to be on the lookout for. So you see, this is important to know. You're not going to do any kind of exams below the waist. Refer that to their primary care. Those are deferred in psychiatry. We don't do those. If the patient has questions about health concerns, you can help by teaching them to be their own best advocate and to advocate for themselves. You can help them organize their interests, recruiting a support network to raise these issues to their primary care provider, because you're not going to treat them. You're going to refer them. But you can be very instrumental in helping them gather their thoughts and knowing what they should be asking their primary care provider. You will provide anticipatory guidance through diagnostic and treatment phase if appropriate. So anticipatory guidance, it is on your psych evals. So that is something that we do. Now these next slides, these are just for your information. You do need to know the cranial nerves. I do have them listed out for you. I'm not going to go over all of them. You learn these in advanced assessment. You will be tested on cranial nerves. So if you can't remember them, you can look at this little mnemonic. Oh, 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 to touch and feel very good. Velvet, ah, heaven. So that may help. There's several different mnemonics for cranial nerves. I found this one to be the easiest. Oh, 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 to touch and feel very good. Velvet, ah, heaven. So, olfactory. Put your cranial nerves where you can remember olfactory and optic 1 and 2. That originates from the cerebrum. Ocular motor, trochlear, those are motors and they come from the midbrain. Trigeminal nerve, sensory and motor. Abducens, facial, all of those are from pons. Vestibular, tracheal, that is also from pons. Glossopharyngeal, vagus, accessory, and hypoglossal, those are from the medulla. Now, am I going to ask you where they originate from? Nope. But am I going to ask you possibly ocular motor for the eye movements, pupil reaction to light and convergence? That's quite possible. What about trigeminal? That would be important, right? For face sensation, jaw movement. Facial, spontaneous facial movements, right? This is things that we should know. These are things that you're going to test for. So yes, you will have cranial nerves on your exam. Now, labs, I'm not going to go over all of these, but you will have a copy of these labs. You have the normal values, when you may see increased levels, and when you may see decreased levels. So I have a complete blood count for you, a chemistry profile, liver function tests, common thyroid panel, and some common psychotropic drug levels. I also have those listed for you as well. Now we are wrapping up, almost done. So let's talk about the approach to clinical problem solving. So first you have the approach to the patient. That's where you're doing your comprehensive psychiatric evaluation, which you will do 5 of those in this course. Approach to clinical problem solving. You're going to be making a diagnosis, assessing the severity of the disease, rendering treatment based on that disease, and you're going to be following the patient's response to the treatment. For the approach to the Diagnostic and Statistical Manual of Mental Disorders, we use that to assess for the severity of the disease, to render treatment based on the disease, and to follow the patient's treatment. So we're using the DSM throughout their treatment. Remember, you will use that DSM often. And then approach to reading. Patients aren't going to come in cookie cutter. Mental health is not cookie cutter. So you're going to do a systematic researching of the disease. Patients rarely walk in with symptoms that permit a clear diagnosis. It's very rare. They usually have a multitude. So you should become skilled in applying the diagnostic criteria from the DSM-5 information in your clinical setting. You're also going to utilize clinical rating scales and screening tools that can help you improve your diagnostic accuracy and quantify the patient's presenting symptomology. I always tell my patients, I don't treat a rating scale. I treat the patient. I do use them. I do the PHQ-9 and the GAD-7 pretty much every visit, but I don't treat those. I treat the patient. All right, here is just a list of some clinical rating scales. You do not have to memorize these. You will see several of them throughout this semester. I don't even have the PHQ-9 and the GAD-7 listed. They're so common. You will see those in a later lecture. These are just some of the clinical rating scales that you can be on the lookout for this semester. Okay, and that is the end of this lecture. If you have any questions, please reach out and let me know. This material will be provided for you. You will have a PDF in the course that you can print and follow along.